This lecture is just about muscle, and muscle is an extremely specific topic, but it kind of nicely bridges calcium and phosphorus, and then transitioning to liver when we're talking about enzymes. The main things we're going to talk about with muscle are CK and AST, and they're both enzymes. And then we're actually going to talk about muscle injury and how it can impact our chemistry panel and even our urinalysis. But let's just quickly kind of talk about some of the diseases of muscle. And I'm not going to test you on these, but we are going to go through some cases. And I'm not going to go through all the ones listed in the notes. I'm just going to go through some of the more common ones. In the notes, I used the Damnit V scheme, so the developmental, anomalous, neoplasia, infectious, inflammatory, idiopathic, inherited, trauma, and vascular. I'm not going to necessarily, again, go through all of those, but if you want to follow in the notes, certainly. So a common thing that we can see, especially in large animals that have been exerted or dogs with heat stroke, is you can have capture or exertional rhabdomyolysis. So, and this is essentially muscle death and destruction from either heat, from capture, maybe the animal ran around a lot, they've exerted themselves, or an animal that actually has hyperthermia. Another one to consider are certainly nutritional causes, and this isn't one that's necessarily easy to really go over in blood work. Certainly anybody thinking about doing large animal medicine has to consider nutritional causes such as vitamin E or selenium deficiencies. And then we kind of get the eyes, and there's a lot of these. So there's numerous infectious causes, and I'm sure you can't be at Penn without learning about Toxoplasma. Infectious diseases can be protozoal that actually insist in muscle. They can be systemic bacterial infections, so bacteremia can potentially do it, although that would be relatively uncommon. You can have certain bacterial infections that are focal, so think about clostridial infections in large animals. And then there's kind of non-infectious, inflammatory, and that's some of the immune-mediated myositis, so inflammation of the muscle, and those are all possibilities. You can have some inherited diseases, which we're not going to talk about. Trauma is a really good one to think about, and trauma could be something like hit by a car, or it could even be an animal that's maybe seizuring. When we did the calcium cases, those animals, since of course calcium is so important for your neuromuscular function, when you are really low in calcium, you can have abnormal neuromuscular function. Animals can seizure, and that can impact your muscles, of course. There's some toxic causes. We're not going to talk about those. Oh, I forgot to mention trauma, especially large animals, so down animals. Remember, these guys have a ton of muscle, so when they're down, they're actually damaging their muscle because they're down. Then you can have ischemic events, so potentially DIC itself could actually lead to muscle injury. So now let's actually talk about how you identify muscle injury. So CK stands for creatine kinase, and note that this is not creatinine, this is not the same thing, and that CK is actually a catalyst within the muscle, and it converts ADP and another substrate into ATP, and you don't really have to know that. What you do have to know is the fact that CK is extremely muscle specific, meaning it is low in the plasma, high within muscle, and it's what's considered a leakage enzyme. So if here's your cell, and here's your cell nucleus, CK lives in the cytoplasm. So if your cell is damaged, it's going to leak out CK, and that's going to go into your bloodstream, and then you'll see an increase in it. And that happens very quickly after damage or death to myocytes. So you're going to see that increase in CK. It doesn't have a very long half-life, so it goes away quickly once the injury goes away. Increases in CK can be marked. Usually we ignore anything that's really less than 2, even up to 3 times potentially the upper reference limit. We don't get too excited. We might worry that there's a little bit of muscle injury, but it may not be the primary problem happening. Once we start seeing it greater than 3 times, we worry more. But when especially large animals, you can see numbers that are, 100-fold higher potentially than what is actually normal for your reference range. And again, this is not the same as creatinine, so muscle injury is not going to increase your creatinine. And again, this is considered a leakage enzyme, meaning when there's cell injury, it's going to leak. The other leakage enzyme is something called AST, and AST is a little bit less liver specific, muscle specific, so we can see it leak from muscle, we can see it leak from liver, and it can actually leak from red blood cells, but that's more of an in vitro. So it's less specific. It increases a little bit slower than CK does, and it lasts a little bit longer. And again, it's also liver. So we're really going to focus on CK, and then next week we're going to do liver things. So now we're going to talk about kind of the other blood work changes you can see with muscle injury. So I mentioned in the calcium section that muscle injury can actually cause hypocalcemia, and I'm going to tell you about how that happens. So on the left, that's muscle, and on the right is your blood. And so let's talk about what happens. Well, so if muscle has a lot of ATP in it, yes, that P is phosphorus. So if all of a sudden all of these myocytes die, it's going to release phosphorus, and so you're going to see an increase in phosphorus in the blood. So what happens to calcium? Well, when you have this sudden release of phosphorus, both free within this dead space, right? So you're going to have free within this dead space all this phosphorus. Calcium is going to bind to that, right? So you're going to get calcium binding, and you're going to get mineralization. And so you're going to see a decrease in calcium in the blood, and that's that. So it's muscle, but it's related to the union. And that may happen, it may not. None of these things are absolute. So again, one thing that happens is you have increased phosphorus, and you're going to have a decreased calcium. So what else is high within cells? Well, potassium. So potassium is within the cells, so inside of the cells, and with cell death, potassium is going to be released, and you're going to see potentially an increase in potassium. So that would be one other thing. Another thing is that all of this dead space, kind of where the muscle was, sodium and chloride can go against their concentration gradient, and you may see a decrease in sodium chloride, but that's extremely uncommon. So the big things you're going to look for is of course, number one, you're going to look for an increase in CK, which may not be present on all blood work. So if you don't have that, the next thing you're going to do is you're going to look for an increase in AST. Now, if you have an increase in AST, right, so it's increased, but CK is not, it's not muscle injury for our purposes. And then next week we'll talk about actually checking something called ALT in small animals, and it's liver. And so if it's increased along with AST and you don't have CK, we're going to talk about the fact that maybe it's not muscle. So we're not going to talk about ALT right now, but realize that what we really want to see is this increase in CK. And then once you have that, or if you've noticed these others, you're going to look for increase in phosphorus. Of course, that's from the release of ATP. And then you're going to look for a decrease in calcium. It may or may not be there. Of course, it's the increase in CK that's number one. And you may see an increase in potassium. Something else to realize that, of course, muscle contains myoglobin. That's actually kind of the hemoglobin version in muscle. And so, of course, myoglobin is small like hemoglobin. So if you have really severe muscle injury, so we're talking thousands, right? So thousands increase in our CK. We're not talking like a mild increase. You can get this release of myoglobin. You don't see it increase in the serum or plasma usually, but it's freely filtered by the glomerulus, right? So here's our glomerulus in our blood. So myoglobin actually goes in, and it's freely filtered, and it goes out into our urine. And well, what does it look like? Well, it gives you a positive blood on your dipstick because of the globin, except you'll have a negative sediment. And your urine may be kind of brown or reddish brown, potentially. It just kind of depends what all is going on. Now, in real life, it can actually be really hard in very sick patients to tell the difference between myoglobinuria and hemoglobinuria. So, of course, what are you going to look for? You're going to look for that increase in CK, and you're going to check a patient's PCV. I just had a case today, and I really couldn't tell the difference when I was looking at the urine and looking at the blood work. So we will practice some of these cases. All of our cases are going to have increases in CK. Next week we'll talk about AST, and we can kind of practice calcium and phosphorus a little bit more as well.